Good evening. Today, the ICS is bringing you a webinar on true severe asthma as part of the Obstructive Airways Disease webinar series. My thanks, first of all, to Dr. Sandeep Salvi, the president of the Indian Chest Society, Dr. Amita Nene, who, apart from being the chair for education, is also a live wire, as everyone knows, and has been involved with organizing this program right from the beginning. And of course, Dr. Raja Dar, the Maharaja of pulmonology in our country. They're doing a splendid job of bringing you these webinars. We have a great panel today. We're starting with Dr. Mahavir Modi, who's going to take us through a talk on true severe asthma. He actually needs no introduction. We've all heard him very often. He's a consultant pulmonologist at the Ruby Hall Clinic since the last 20 years, and the director of the Modi Clinic, subtitle Excellence in Chest and ENT in Pune. Executive Management in Healthcare qualification from the University of Virginia. He was awarded the Inspiring Chest Physician Award 2023 by the Economic Times of India, the Lokmat Dhanvantri Award of Pune in 2021, the Bharat Ratna Indira Gandhi Gold Medal Award by GEPRA in Bangalore in March 2019. He's also an ardent interventional pulmonologist who's been trained by the great Dr. Stefano Gasparini and has several publications. Apart from being an extremely good pulmonologist, he's also a good friend and a really wonderful person. So we'll start with a talk by him, and then we'll come to the panel, and I'll introduce the panel at the appropriate time. Dr. Modi, over to you.
Thank you, sir. Thank you for such a nice introduction. And thank you, Team ICS. Thank you, Dr. Amita, Dr. Rajadhar, Dr. Sandeep Salvi, sir. So can I please share my screen? I should be allowed.
You can share, sir.
Yeah. Make it on a full screen mode. Yeah. So my today's talk of about 20-25 minutes is about true severe asthma. How do we diagnose these patients, and what is the treatment or the different treatment options? So as we all know, asthma basically has airway hyperresponsiveness. It also has reversible expiratory airflow limitation. And now we know that it's a chronic airway inflammation. So that's the reason many of our asthmatic patients, they have a very long-standing history, and then they become severe asthmatics. The severe asthma in India, in my clinical practice, also around 5 to 10% of the total asthma population, they have severe asthma. And among subjects with severe asthma, the studies have shown that almost 70% of the subjects were never diagnosed with asthma. So maybe the first time they come to you, and that is how they may land up with severe asthma. So even a mild asthmatic patient can land up in ICU and can convert into severe asthma. So that is acute severe asthma. And today's talk, I am not going to talk about acute severe asthma, but we are basically going to talk about the different phenotypic approach for these patients of severe asthma. So why this is important? Definitely because if you see the cost burden, almost 60% of the cost burden is because of these severe asthmatic patients. In our clinical practice in day-to-day life, we come across certain patients, those who have uncontrolled asthma. And this uncontrolled asthma may be or may not be severe asthmatics, because there is another subset of these patients which are called difficult to treat asthma. And not all patients of severe asthma not all patients of difficult to treat asthma are actually severe asthmatics. So when we have in our clinical practice, a lot of patients, those who are not responding to the treatment and they are already on high dose of inhaled corticosteroids plus high dose of LABA, they may be on certain other medications like LAMA, then maybe your leukotriene inhibitors, plus they can be on methyl xanthides. So these can be the patients, those who can be either difficult to treat asthma or severe asthmatics. So we had one seminar on this about how to differentiate between these two. But just to brush up, that severe asthmatic patients are just a subset of difficult to treat asthma. They both are GNAF 5 or GNAF 4. they both have poor symptom control. But when we say difficult to treat asthma, they definitely have certain modifiable risk factors. And if we modify these risk factors, then many of these difficult asthmatic patients are actually not severe asthma. So what are these patients of difficult asthma? They have poor symptom control score with ACQ score of more than 1.5. They have frequent exacerbations, maybe more than 2 courses of steroids in the last year. They may have one hospitalization requiring ICU, and of course they have airflow limitation. So these are all difficult asthmatic patients, and despite of the treatment with high dose ICS with LABA, they still have poor symptom control, and some of these patients may be actually on some dose of oral corticosteroids. But if we modify all of these factors, which can convert their asthma into a more controlled form, and most of these factors are like adherence technique. We all know that our patients have very, very poor adherence, and we have a lot of ways by which we can improve their adherence. The best important is the education, a lot of AI tools, telemedicine. So all these platforms can help to improve the adherence to the treatment. Inhaler technique, which is something which is very, very important, triggers, because many of the times severe asthmatic patients, they may be having a pathway which is actually driven only because of the allergy that is the trigger induced. So we have to take care of all these triggers, and of course the comorbidities. So just like COPD, even we know that asthma doesn't come just as a single disease, but many of these patients, they may have allergic rhinitis, they may have obesity, they may have gastroesophageal reflux disease. So certain kind of diseases which can make their asthma definitely very severe, and that may be the reason that these patients are having difficult to treat asthma. And once all these modifiable risk factors are still uncontrolled, then and then only we can say that the patient is actually having severe asthma. So I always try to wait for at least 3 to 6 months before labeling a patient as severe asthma. It is not in your first or second visit that you label the patient as severe asthma and put them into one of the biological which is available. So before that, we have to look for these 4 modifiable risk factors, confirm your diagnosis, confirm the adherence, confirm the inhaler technique, look for any other comorbidities to treat them effectively. And despite that, if the patient's asthma is definitely not getting controlled, then and then only we can label these patients as severe asthma. So I think that is what a true severe asthma means as compared to just labeling anybody who's coming to OPD as severe asthma. So this is again in a nutshell what we have discussed, but there are certain highlighters which I will like to put in this particular slide. So there are certain patients, those who may have dysfunctional breathing, they may have vocal cord dysfunction, they may have anxiety, they may have obstructive sleep apnea, excessive dynamic airway collapse, tracheobronchomalacia, COPD, bronchiectasis, heart failure. So as a pulmonologist, we all know that we have to basically think and then rule out all other diseases before labeling the patient that he or she is a severe asthmatic patient. So that's what Gina also clear-cut says. And if you rule out all of these factors, around 10 to 15% of these patients are actually severe asthmatic. In my clinical practice, I feel the ratio is less. Maybe around 5 to 10% of the patients are only severe asthmatic. So this is something what we all have read for years together, and Gina has given us a stepwise approach. How do you modify the treatment from step 1, step 2, step 3, and then step 4? But what is most important for the severe asthmatic patients is a step 5 treatment, because these patients are already on high dose ICS LABA. You can add LAMA in these patients, you can add methylxanthines in these patients, leukotriene receptor antagonist. But despite that, and if the patient is requiring again and again oral corticosteroid, it remains important for all of us to phenotype that patient, because not 2 patients of severe asthma are the same patient. So we have to phenotype these patients, and then we can use certain kind of biologics in these patients. And definitely biologics is a hot topic nowadays, and I think it is going to be the future for asthma treatment. And I personally feel that just like rheumatologists are also using biologics, there will be days where we will be using more and more biologics in these patients of asthma. So when we say severe asthma, we basically mean to say that these patients are heterogeneous biologically, and they have distinct patterns of airway inflammation. They may be type 2 high inflammation, or they may be type 2 low inflammation. So how do you differentiate clinically the patient, those who have type 2 high asthma? So these patients basically have eosinophilic airway inflammation, and that you can measure by doing their increased blood eosinophil count, or they may be having elevation of the Pheno levels. So Pheno and the absolute eosinophil count, I think this is true. If we use very frequently in our clinical practice, we should be able to categorize these patients whether they have T2 high asthma or T2 low asthma. Whereas T2 low asthma, definitely they have more of neutrophilic asthma, although we are not doing sputum tests in all our patients, but sputum eosinophils of more than 2% means an eosinophilic asthma. Otherwise, these patients can be polygranulocytic or neutrophilic asthma, and they may be COPD patients, or they may be definitely this non-neutrophilic asthma. Sometimes you may have combination of these two patients, and then it is called mixed granulocytic asthma. What is important is more than 50% of severe asthmatic patients are actually type 2 high asthma. So that is something which can be controlled because they have high level of eosinophils in their blood. So we know that eosinophils are definitely one of the major mediator in these patients. But in severe asthma, more is the number of eosinophil count, as well as then they have more chance of developing severe exacerbation risk, as well as they have poor asthma control as the eosinophil count keeps on increasing. It's a busy slide, but it is very important for us to know the pathophysiology and the treatment options in severe asthma patients. So whenever there are two different types of patients, I will say there are certain patients, those who are allergy driven, and there are certain patients, those who are basically late onset asthmatics and they are not allergy driven. So whenever there is an allergen which goes inside your body, there are certain mediators like TSLP and interleukin 33. TSLP is basically thymic stromal lymphopoietin. This is very, very important because the future therapy of asthma can be by blocking this TSLP by using a drug called tepalizumab, and that can be a biologic for many of these patients, even without phenotyping the patient, whether they are Th2 high or Th2 low. Well, it's a different topic, but at present, we don't have it available in our practice. So how do we go further in these patients? So the patient, those who have allergy-driven pathway. So in these patients, what happens? The antigen is taken up by the dendritic cell. Then the Th2 cells get activated, and the Th2 cells will further release certain cascades because of which the B lymphocytes get activated, and there will be release of IgE, so immunoglobulin E, which will cause mast cell and the basophil degranulation and for causing the further asthma symptoms and signs. Whereas certain times the allergy mediation may not be there, but it may be some pollution, it may be some virus, some bacteria, which is causing inflammation, and because of which there is the release of again this TSLP and interleukin 33, which will involve different kind of pathway, not through the T lymphocytes, but they involve the innate lymphocytes, which are called ICL2, and because of which there is release of interleukin 5, interleukin 4, and interleukin 13, which are very, very important mediators because they will cause activation of the eosinophils, and the eosinophils will further cause the exacerbation of asthma, as well as the mucus plugging and the chronic airway inflammation. So these are two different pathologies which are involved. This is in nutshell because there are a lot of other kind of pathophysiology. This is a pathway which is Th2 high, and there's another pathway which will be not dependent on your lymphocytes as well as on your eosinophils, but that will be neutrophilic pathway where these interleukins are not coming into play, but it's a different inflammatory cascade altogether. So when we have discussed about these certain kind of mediators which are involved, so we know that we basically have certain anti-IgE therapies, we have certain anti-IL-5 therapies, we have certain anti-IL-13 therapies, and then we have anti-IL-13 as well as anti-IL-4 and anti-TSLP. So these are different kind of biologics which are available in our practice and which we should be using in our severe asthmatic patients. So before that, we have to phenotype our patient. And how do we phenotype our patients? Of course, the phenotyping alone based upon the biomarkers is may not be always useful, but we want good clinical history in all of these patients. So basic phenotyping markers are blood eosinophil count of more than 150. This is by far, I mean, in my practice, I say many of our Indian patients may not have, they always have eosinophil count of more than 150. So we may use cutoff of 300 in our clinical practice. Sputum eosinophils, although we are not doing, but whenever facility is available, more than 2% sputum eosinophils. Pheno level, more than 25. Then we can use skin prick testing, maybe for example, for patients with allergic sensitization for finding out the IgE mediated pathway. and then the presence of total as well as specific Ig levels. So if you use these 5 parameters, we should be able to phenotype majority of our patients, whether they're Ig mediated or whether it is eosinophil mediated. As I said that along with this, we should always have a good clinical history. So for that, we have first pathway, which is an allergy predominant or Ig mediated pathway, where it is always an early onset disease, and the patients will have skin prick test or RAS test positive for this aspergillus. Then the Ig levels will be elevated. In my practice, I normally say not even more than 300 up to more than 500. Then we label these patients as having allergy predominant asthma, high phenol levels up to 30 to 50, and they may have a low or normal eosinophil count. Whereas the other pathway, which is the eosinophilic predominant asthma, so these patients are typically late onset patients. They will have skin prick test, which is negative. Ig levels will be normal. They will have high eosinophil count, and their phenol levels will be very, very high, maybe more than 50. And one more characteristic feature of this late onset eosinophilic asthma is presence of nasal polyposis. Whereas in patients with allergic predominant asthma, it is more of allergic rhinitis and not the nasal polyposis. So this is again the same kind of what we have discussed. We have to differentiate patients as Th2 high and Th2 low. And if we have a Th2 or the high T2 high asthma, then we have eosinophils, we have phenol, we have mucus hypersecretion, and then based upon that, different biologics can be used. And if you see the second half portion of the slide, if the patient has T2 low asthma, then the alarmins are same in both of them. These are TSLP as well as interleukin 33. But over here, these patients will have more of neutrophils. These patients may be obese. They may have metabolic dysfunction. And even with the high dose of inhaled corticosteroids, these patients won't respond. So that is how we have to basically differentiate between these two different kinds of population. This is again a busy slide, but the crux of this slide is whenever you are labeling a patient as T2 low asthma, then what we have to do is we have to basically cut down their dose of inhaled corticosteroids. But whenever we are cutting down the inhaled corticosteroid dose, my request is this particular slide says that you have to again keep on doing the phenotypic markers, and maybe many of these T2 low lymphocyte patients are actually T2 high asthmatic patients only, because T2 low asthmatic patients are that way very limited in our country. And plus the treatment options in these patients are limited because many of these patients may require only bronchodilators. They may require anti-TSLP, which is not available with us. Then they may require azithromycin for their long-term to prevent the infections. And then you have to treat their obesity, then laryngeal obstruction, dysfunctional breathing. So those kind of category of patients are basically T2 low asthma. So our particular target for today is basically T2 high asthma. This is something what we have discussed. So when we talk about T2 high asthma, majority of patients from this particular study, almost 83% of the patients with severe asthma have an eosinophilic predominant phenotype. So although Ig mediated phenotype is also very common in our country, and I will just show in my subsequent slide that many of our patients actually will be having overlap of these two phenotypes, and it is very difficult in our clinical practice that we keep on changing our mind from whether it is Ig mediated versus eosinophil mediated. But we all are not wrong, because most of our patients, and studies, even Indian studies have shown that up to 30 to 50% of our patients may be actually having overlap phenotype of both Ig as well as the eosinophilic phenotype. But still, we should be able to phenotype them based upon their history and other clinical features. So when we talk about severe asthma, the most important is how do we manage them? And many of our patients are basically maybe on steroids, or we may be forced to give them steroids. And I also have a subset of patients, those who come to me once in every 3 or 4 months, and I have to load them with oral corticosteroids. And maybe some of the patients where we have to maintain them with a small dose of oral corticosteroids. We won't go in the details of this because we all know about all side effects of oral corticosteroids. Maybe hypertension, diabetes, infection risk, glaucoma, obesity, metabolic dysfunction. So a lot of side effects are there, and I have definitely burnt my fingers quite a number of times by giving steroids to these patients on a couple of occasions. So this particular slide basically shows that it is not only the elderly, but even the younger individuals, those who are put on corticosteroids, they may develop dyspeptic disorders, non-insulin dependent diabetes, hypertension, osteoporosis. So especially in younger patients, I will say that one have to be very careful before putting the patients on systemic corticosteroids. And it has been shown that even the short spurts of steroids, maybe for 4 to 5 days, but on frequent occasions can definitely predispose a patient to a lot of side effects of these oral corticosteroids. So biologics, among the severe asthmatics also, I will say that not everybody is a candidate of biologic. Around 5% of these severe asthmatic patients are actual candidates for biologics. There are 5 approved biologics in patients with severe asthma, and these are basically biologics for this Th2 high asthma. And the one which are available at present are omalizumab, mepolizumab. Preslizumab was intravenous and it showed has some black box warnings. That's the reason that it has not been available now. Benralizumab and dupilumab. So these are 4 biologics which are available. Out of them, omalizumab is anti-Ig and has been recommended from the age group of 6 years onwards. But the disadvantage of omalizumab is that the body weight as well as the total dose of Ig can be very, very high, although it has now got some approval for food allergy as well as for patients with ABPA, where it has shown promising results and we have maximum data or maximum experience with this particular drug. And I'm very happy for using omalizumab, especially in the allergic population only. Then we have mepolizumab, which is anti-interleukin 5. And then we have benralizumab, which is anti-interleukin 5 receptor antagonist. So mepolizumab has been studied as a once a month therapy with 100 milligram, and it has been used for more than 6 years of age group with eosinophilic asthma. Similarly, benralizumab for again eosinophilic phenotype, and now the age group has been decreased to more than 12 years. It has been approved. And recently data has come where it can be used even from the age group of 6 years onwards, which is yet to be published, but very soon the benralizumab will be available even from the 6 years of age group onwards. So the basic advantage of benralizumab is for first 3 dosages, it should be given once a month, and then it is once in 2 months. So in a year, the patient has to take around 9 dosages in the first year, and then from next year onwards, the dosages will be less. And dupilumab, although it is not yet available, but there are studies, and I was fortunate to be a part of this particular study where it's an anti-IL-4 as well as anti-IL-13 kind of drug, and it can be used in patients with asthma as well as in patients with chronic urticaria. So these are the different biologics which are available. What is important for all of us to know that, as I mentioned, that it is not only the bronchoconstriction, but it is the inflammation and the chronic airway remodeling, which is very, very important. And as we know that interleukin 5, which is one of the very important mediator in asthmatic patients. So what happens is eosinophils basically, this interleukin 5 is basically responsible for the activation and recruitment of the eosinophils. But that is not the only role of interleukin 5. Interleukin 5 is also responsible for loosening of the tight junctions of the airway epithelial cells. Also, it is also responsible for activating the fibroblast proliferation, and it promotes the airway remodeling, so which is very, very important in the chronic pathophysiology of asthma. Plus, eosinophils can directly stimulate the remodeling by release of certain mediators like TGF-beta. So why I want to stress on that is that maybe they have roles even similar, these drugs, the anti-IL-5 drugs, they have roles similar to corticosteroids or the inhaled corticosteroids, and there may be days where we may be using more of biologics and less of inhaled corticosteroids in these patients. So after discussing about these 4 biologics which is available, so what is very important to us is to know that we have now a lot of population of patients, those who are already on biologics, and how do you follow up on these patients with biologics? So suppose you have put a patient on one particular biologic, then if the patient is responding to the treatment, continue with the treatment. If the patient is not having good response or if there is a suboptimal response, always one has to do reassessment and find out whether our phenotyping is right or if it is wrong. If the patient is having neutrophilic inflammation, then one has to consider using certain different kind of therapies. As I said, weight reduction, macrolides, and then maybe bronchial thermoplasty, although it is not being used nowadays and the studies are quite against biologics. Maybe more of biologics which we have started using in our clinical practice. But however, if the patient has still eosinophilic inflammation, then one has to consider that whether the patient is adherent to the overall asthma management plan along with your biologic, because many times patients feel that once they start with the biologics, they can discontinue with their inhaler, which is not true. Eosinophilia is not driven by the pathway targeted by the biologic use, or there may be some other reason for eosinophilia, maybe like eosinophilic granulomatous polyangiitis or some other kind of disease which is the actual cause for eosinophilia and not only the severe asthma. There may be inadequate dosing, that is also quite possible in many of the patients. There is a concept of development of neutralizing autoantibodies in these patients, and other immune mechanisms also may be developing. So one has to reassess after 4 to 6 months after starting biologic in these patients. This study, which is very important, these are ISAR study and the chronicle study. It is very important for all our patients to understand that once you put the patient on biologics, many of these patients, they will actually continue with the biologics. And this particular study shows that almost 80% of the patients will continue with biologic therapies because they get so much of efficacy with these drugs. And even I have patients where I have asked them to stop biologic, but these patients will say that no, they want to continue because of the whatever benefit they get out of this. So it's a definitely wonderful therapy, and one has to phenotype and then put the patient on right biology. So I think I have a few more minutes. I will just go through certain last slides. So certain slides are taken from GSK and certain from Astra because they are the ones which are available at present, and they have given me some important data. So there are a lot of studies about this mepolizumab, and mepolizumab has been used very frequently in patients with severe eosinophilic asthma, and almost all these studies show that the exacerbations as well as the reduction in the oral corticosteroids, and in certain patients, almost in 50% of patients, the oral corticosteroids could be completely stopped. Now, there is this one very important concept that when you are putting a patient on biologic, whether a patient has achieved complete remission because of this asthma. So it is very difficult to have complete remission. But when we say that a patient has clinical remission, that means that the patient is not on oral corticosteroid when the biologic is started. Plus, there is a improvement in the clinical symptoms with ACT score of more than 20 or ACQ score of less than 0.75, optimization and stabilization of the lung function, and both the patient as well as the doctor, they permit that the patient is having disease remission. So when all these 4 criteria are met, then we can say that the patient is having clinical remission. So there are different studies and different trials, which I won't go in the details of this. But when you are saying all 4 factors are met and if the patient is having clinical remission, so with mepolizumab, almost 30% of the patients, they could get complete remission when you are considering all these 4 factors. When you are considering only exacerbation free and the oral corticosteroid free, almost 50% of the patients, they could be managed without oral corticosteroids with this mepolizumab injection. This is one more very important study, which is for the benralizumab. This is a SHAML study, and this was basically to find out the reduction of maintenance inhaled corticosteroids in patients with severe eosinophilic asthma. So these patients, those who were put on benralizumab, and in these patients, they were already on high dose of inhaled corticosteroids along with LABA. And as early as 3 months from the start of biologic, these patients' inhaled corticosteroid dose was started reducing, and it was up to the extent that almost 92% of the patients reduced their inhaled corticosteroids and formoterol dose, and out of them 61% of the patients, they could completely stop their daily requirement of ICS, and they could be actually converted to as and when required ICS formoterol combination for your rescue therapy or smart therapy. So this is something which is very important, that many of the times biologics can not only stop the oral corticosteroid and decrease the dose of oral corticosteroids, but even the inhaled corticosteroid dosages also can be decreased with this particular biologics. This was again one very important paper which is recently published in the ERJ, and we all keep on talking and we get driven by the companies by whatever is their data. But this particular study was from the UK Severe Asthma Registry about the clinical remission in severe asthma. So again, in this patient, the clinical remission in particular, this particular study was defined as no use of systemic corticosteroids, significant absence of symptoms, lung function optimization, and both patient and the provider agreement that clinical remission has been achieved. And as per this, and UK is very strict about putting the patients on biologics because here the government is paying for the biologic and not the patient. So the primary definition of clinical remission was what I just discussed. And what was the conclusion? And they were different biologic. It was not only for one particular company, but there were patients, those who were omalizumab, mepolizumab, benralizumab, all kind of biologics were there. And almost 18.3% of patients achieved the primary definition of clinical remission. And remission was more likely if the patient was T2 high biomarker as compared, and those who have shorter duration. And the patients, those who could not achieve remissions, were actually female patients, obese patients, or those who have ACP score of more than 1.5 before starting the biologic therapy. This is again one more interesting thing that we know that both the Bepoli as well as benralizumab has been used in patients with eosinophilic granulomatosis with polyangiitis. But the clinical remission in these patients may be different as compared to what we see in severe eosinophilic asthma patient. So this particular paper shows that the super responders to mepolizumab and benralizumab in patients those who have eosinophilic granulomatosis with polyangiitis along with severe eosinophilic asthma. So in these patients, those who had very worst kind of symptoms at the beginning of biologic therapy, they are actually super responders as compared to severe eosinophilic asthma patients, where the patients those were less symptomatic, they had more chance of developing clinical remission, but this was other way around in super responders in benralizumab group. And in this particular paper, benralizumab had an upper edge as compared to mepolizumab. So just 2-3 slides more, and we want to know about the newer biologics. So we have this one tezepelumab, and AstraZeneca has having trials about this. And this particular was tezepelumab is basically it's a TPSP, which is an alarmin, which is induced by any kind of allergen. Let it be allergen, let it be pollutant, virus, bacteria, anything goes inside a patient who's having asthma or severe asthma. So then these patients, they will have this particular mediator, which is TSLP, which is a thymic stromal lymphopoietin. And the tezepelumab will basically block this TSLP. So this happens at a level much, much higher as compared to what our eosinophil and IgE mediated pathway. So if you have one antibody which is actually blocking the pathway at a much higher level, then maybe you don't have to actually phenotype our patients. Even if it is Th2 high or Th2 low, at both the places, this particular can block the alarmins and can cause a degradation of the asthma cascade. So this can be actually a game changer. This is by AstraZeneca, the medicine which is going to be available. There was a navigator study and it showed that there was significant decrease in the asthma exacerbation as well as the symptoms of asthmatic patients. So where will it fit? Definitely it will be for the GINA step 5 and it can be used even in non-eosinophilic severe asthmatic. So as I said that whether newer biologic can it stop inhaled corticosteroids completely, although I think we should not discuss, but there was one particular paper which showed that this is one particular drug which is itepekimab, which is an anti-interleukin 33. And this was a very short study of only around 2 weeks. And over here, the patient, those who were given this particular antibody, they could stop their inhaled corticosteroid completely. So that can be game changer in the future. And I mean, then we may not have any side effects of inhaled corticosteroids, but I think science is evolving up to that period. So just to cut my story short, to summarize, we know that uncontrolled asthma is not severe asthma. True severe asthma are subset of difficult to control asthmatics after modifying all modifiable factors which I mentioned up to 3 to 6 months. Allergen sensitized individuals and eosinophil mediated asthma have different mediators at cellular level. So we have discussed about these two, where the interleukin 5 comes into play, and over here the T lymph, the Ig levels come into play. Interleukin 33 and TSLP are the major alarmins, and if you can block them at a higher level, then the further cascade can be stopped. Although eosinophilic pathway is predominantly associated with exacerbations in severe asthmatics, we do get a lot of overlap population. We have biomarkers, but we have to use them with clinical acumen and history, and then only we can phenotype our patients. We have discussed about 4 or 5 different biologics which are available, and they all have definite different roles to play. Interleukin 5 inhibition has a role in preventing airway remodeling and can change the pathophysiology of asthma. Then we have discussed about the IL-5 inhibition as a role in even eosinophilic granulomatous polyangiitis management. Data in SHAML study shows that dose of ICS can be tapered significantly as early as 3 months after starting biologic. And in UK registry, significant clinical remission could be achieved in 20% of severe asthmatic patients, those who are given biologic as per their requirement. And females, obese, higher baseline asthma control test score, longer asthma are all poor predictors to achieve clinical remission in severe asthma. So one has to choose our patients wisely. So I think this was the last one. Thank you very much for patient listening, and any comments I will like to take them. Thank you, sir.
Excellent talk, Dr. Modi. I learned so much from your discussion. And I think we will learn more in the panel discussion as we go along. We have an excellent panel today. And I think we're going to take up a lot of these points again, because as Dr. Amita Nene keeps reassuring me, repetition often is very useful, and people sometimes join a little late, so they might have missed some of the key points that you made. But thank you again for that excellent talk. Before I go any further, I must thank Lupin and the technical team behind this for doing a splendid job every week, bringing us, quality presentations and quality discussions here. And again, we have more than 1,400 logins. So clearly, this is a very, very popular panel. Aditi, can I have the other slides, please?
Yes, sir.
Yes.
Yeah, so I think right now there are 1,632 logins. So testimony to, of course, not just Dr. Modi, but also the rest of our panelists, all of whom are brilliant. I've introduced Dr. Modi already. Dr. Prasanna Kumar Thomas, great friend of mine, somebody I admire hugely and have done so for many, many years. He is a graduate of the very prestigious Madras Medical College. I don't know how many of you know that it's probably the oldest or the second oldest college to be started in our country. It's a matter of dispute between the Calcutta Medical College and the Madras Medical College people. But there are just a few days that separate them. He also did his post-graduation from the same institution, got the K.V. Krishnaswamy Gold Medal for the best outgoing MD postgraduate. He's currently a consultant pulmonologist at several of the major hospitals in Chennai. He's, of course, a specialist in the areas of airway diseases and smoking cessation. And he's very actively engaged in promoting medical education for professionals and smoking cessation for the public. Another very, very important area of interest of mine also. Not just this, he does a lot of free medical camps and awareness programs because of his social commitments. And he's done such events all over the country, even in places like Orissa and as far as Assam. He was an invited speaker at the WASOG meeting at Beijing in 2017. And his dream is a tobacco-free India. And of course, that's a reflection of the wonderful person that he is. It's great to have you here, Dr. Thomas.
Thanks, Vande.
Our next panelist is Dr. Pratibha Dogra. She is a senior consultant at the Marengo Asia Hospitals in Gurugram and the vice president. In fact, that's how we know her best, as a person who's specially interested in sleep and is pushing the science and the practice of sleep medicine in India. She's the vice president of the Southeast Asian Academy of Sleep Medicine. Several training programs, over 50 in sleep medicine, more than 50 respiratory medicine training program, many publications, memberships across a variety of organizations, and has done her fellowship in sleep medicine from Medanta Hospital. She's done a lot of work on sleep apnea India in registry, sleep in Indian teens and young adults during the second wave of COVID. These are her latest key research works. Dr. Dogra, as you know, is in Medanta, Gurgaon also. So welcome, Dr. Pratibha Dogra. It's great to have you here. Our next panelist, I heard her recently for the first time, and she did a wonderful job. Dr. Nishita Singh is the executive director and senior chest consultant of the Global Asthma Network, steering group member. She is based at the Asthma Bhavan in Jaipur, which you know is one of the major institutions started by Dr. Veerbhadra Singh and has other luminaries like Dr. Shitu, who focuses on ILD, while Dr. Nishita focuses on obstructive airways diseases. A lot of publications. Recently got the best publication for Lung India on EBUS and the BronchoCon 2019 Best Research Paper Oration Award. Welcome, Dr. Nishita. You shared a lot of your knowledge at the ILD meet, and I'm looking forward to hearing more from you here.
Thank you for the kind introduction.
Last but not least is a brilliant young person, another Best MD Award winner, Dr. Avya Bansal. Heard him also at this ILD summit, and as usual, he was brilliant. He is a consultant pulmonologist and sleep disorder specialist at the Bombay Hospital and Medical Research Center, and an honorary pulmonologist at the Mumbai Police Hospital, and has the lung care clinic in Bandra. He won a scholarship in the MBBS, the Sir Ratan Tata Scholarship. He was the university topper during the MD. He won the ICS ERS travel grant for the best paper in Madrid. And you know, that's not easy. He has 10 national and international publications, and his special areas of interest are obstructive airways disease, OSA, and ILD. And very importantly, again, an area close to my heart, he set up the adult vaccination OPD at Bombay Hospital, recognizing that prevention is far more important than cure. So welcome, Dr. Avia. Look forward to hearing you as always.
Thank you, sir. Now, can I take this opportunity to introduce our wonderful moderator who really does not need any introduction? I've learned from him since my training was in Karnataka, Dr. Murli Mohan, sir. He's a senior consultant and academic director at the Narayan Majumdar Shaw Medical College Center, in the Department of Internal Medicine and Pulmonology. Sir has been a past professor and head of department at the B.R. Ambedkar Medical College in Bangalore, has received 6 orations and awards, has over 80 papers, posters in national, international journals and conferences, has authored chapters in 5 books, has been a joint author of the WHO Manual of Tobacco Cessation for doctors and dentists, has trained more than 90,000 persons in CPR in Karnataka, has been a former editor of the Karnataka Journal of Medical Sciences, the Journal of Internal Medicine Research and Reports, is the chairman of the API chapter, has a special interest in ILD and pulmonary vascular diseases, and is also a national quiz champion. Apart from this, a wonderful human being and has inspired young budding pulmonologists like myself for years and years and years. Thank you, sir.
Thank you so much for that very kind introduction, Dr. Avia. But we really, Dr. Thomas and I, recognize that the time has come to pass the baton on to the others on this panel. So we'll move on to the discussion straight away. I'll be starting this questions that I have for you with, of course, the senior most on our panel, Dr. Thomas. Dr. Thomas, how do you assess asthma control? Because that's key to understanding where we are with the patient and when we move on to difficult to treat and severe asthma. So how do you assess asthma control in your clinic?
Thank you, Dr. Murli. It's a great opportunity. I thank Dr. Salvi, Dr. Nane, and Dr. Nene, and my friend Dr. Raja for having given us this opportunity and this platform to be here. I think it's a pleasure, a privilege, and an honor. And Dr. Mahavir, I'd really like to compliment you on that brilliant talk. I think it's one of the best talks that I've heard for a very long time. Congratulations, and God bless you for that. Wonderful. I think the definition of what you have given here as true severe asthma has literally let the cat out of the bag. It means that your asthma is dependent on the setting in which you look at the asthma. That's really what it's all about. Asthma control is not boxed into a guideline, but is let out into the open, and your asthma control depends on where you work. If you work in a sort of down-the-line clinic where all that you have is a table and a chair, a prescription pad, a pencil, and an old rickety BP apparatus, your asthma control is going to be different. Your perception of asthma control is going to be different. If you work in a sort of posh institution with a high suite on the 5th floor of a 18-story building, I think your asthma control is going to be different. My asthma control, if you ask me in my daily practice, when I look at patients and come back, the only question that I would ask patients is how comfortable are you? I won't be looking at things like pulmonary function tests and this and that, and look at the eosinophils and look at the phenotype and all those things. I honestly don't have the time for such things. So that's the nature of work that I have. So in this sort of situation, my thing would be purely clinical from this point of view. I would say, are you feeling better now? Are you off your short-acting beta agonists? Are you taking your ICS regularly? Are you doing your morning walks regularly? How comfortable are you sleeping? I think these are the questions that I need answered. And if he answers these questions satisfactorily, I'm fine with that. The other caveat is the person who sits on the 5th floor. And now this person will look at all these other things that I talked about. We look at pheno, we look at pulmonary function tests, we look at 6-minute walk distance, we look at all sorts of things for asthma control. So asthma control in general depends on where you are.
Thank you, Dr. Thomas. As usual, you bring a lot of common sense to any question that's asked. what I usually do is I go by either the GINA guidelines, which tell us that you go by symptoms, daytime symptoms, nighttime awakening. Do you need more of your reliever medication more than twice a week? And is your activity limited in any way? Because that's what the patient is interested in also. He wants to be able to do everything. And I very often find it useful just to give them the asthma control test while they're sitting outside. They fill that in. And again, it's all, self-filled in. So it's ready for you when you come in. And I agree with you. I don't go by lung function tests and so on. They're really not meaningful in the clinical context. So questions, symptoms, and how limited is the person in the activities that he or she wants to do. My next question goes to Dr. Pratibha. Dr. Pratibha Dogra, what's the difference between difficult to treat asthma and severe asthma? And in your clinical practice, can you tell us how common these are? How common is difficult to treat asthma? How common is severe asthma?
Thank you, Dr. Murli, for the kind introduction. Good evening, everyone. And yes, Dr. Mahavir has actually covered everything very, very beautifully and very, clearly. So leading from the first question only, how do we assess the asthma control? So I think to understand, what is difficult to treat asthma and severe asthma, we should understand the concept of uncontrolled asthma. And as Dr. Murli just said, that uncontrolled asthma will need to understand the symptoms control. So if the patient is having uncontrolled asthma, which is usually defined by the symptoms frequency is more, or the relievers they are using is, frequency is more, there's a limitation in the physical activity, or the nighttime awakenings are there, or the exacerbations are more, or even there's a history of hospitalization in such patients. So that is how we will label that patient has uncontrolled asthma. Now, further to uncontrolled asthma, difficult to treat asthma will be that uncontrolled asthma in which the patient is being prescribed medium to high dose ICS along with another controller, along with maybe even oral corticosteroids. But still, the asthma stays uncontrolled, or if they try to decrease the dose, again, the asthma becomes uncontrolled. But in this case, this is not that all difficult to treat, asthma is a severe asthma. So there, as Dr. Modi also told us about what are the modifiable factors that we should be looking at, and we should be treating them. And in case we have done with that we have, ensured that, the diagnosis is correct, or, the inhaler technique is correct, or the adherence is there, or, other contributory factors like comorbidities, like obesity or GERD has been taken care of, and still the patient is not improving, and that maybe that we have to follow up the patient for 3 to 6 months, then we'll come to severe asthma. And per se, I will say that severe asthma, by now, it is more like, it's like, the label that can be go in in retrospective only, we can label a patient of severe asthma, like after having observed the patient for 3 to 6 months. So now this patient whom we have given maximal optimized therapy, and the patient has adhered, and we have taken care of all the contributory factors, and still, the patient is having uncontrolled asthma, that is when we label the patient as severe asthma. I think the only take I would like to take here, and going by my own practice, it's not that we have to. I mean, any patient who walk into our clinic and for the first time we are trying to diagnose this as an asthma, rather than to wait till the time it becomes difficult to treat asthma, we should be taking care, a detailed history, which help us to understand that this patient doesn't have any other contributory factors at the point one, the first contact we have with the patient. So that is how we can change the practice rather than keep on waiting for that. And yes, if we go by the percentage of patients in my OPD, to be honest, I think it will be 5 to 15% will be difficult to treat asthma, and I'll just keep it 2 to 4% very severe asthma, because that is where we are. Maybe I'm working in a corporate hospital, and this is population we have. The cohort of patients, they're well educated, and adherence a thing is not a problem in our setups where I have practiced.
On the other hand, because we work in a corporate setup, we may be getting more referrals of the difficult to control asthma. So, that works both ways. So it's actually very difficult to put an actual number on it, but it's nice to get a rough idea of what our troubled population is, troubled and troublesome population is. My next question goes to Dr. Nishita, and thank you for that excellent answer, Dr. Pratibha. You spoke about the comorbidities that need to be excluded. So, Dr. Nishita, specifically, what comorbidities do you exclude and how do you exclude them before you label a patient as severe asthma?
So hello, sir, and hello to everyone. Basically, whenever the patient comes with a diagnosis of asthma, so there are certain things when we have to decide whether it is asthma or it is actually some other illness. Like our old friend, that is COPD, it often mimics like asthma, and there's this new entity called as echo that like mimics like asthma. And so this is one thing, because the patients present with cough and breathlessness. Similarly, there can be a complication of asthma, that is ABPA, that in which there is bronchiectasis, and a similar entity that is post TB bronchiectasis, that also patients complain with chronic sputum production as well as breathlessness. So you need to like really be alert and vigilant enough to catch these entities first and to diagnose. As well as there are other diseases that we need to be careful about. One is the obesity. So obesity is one thing that has been proven before and now, that it has been associated with high association of asthma, both in children as well as in adults. As well as with obesity, there are other diseases like gastrointestinal reflux disease. So it is one thing that goes hand in hand with asthma. So you need to treat asthma side by side. You need to treat GERD also, because it plays a role in increasing the exacerbations or increasing the symptoms of asthma. And apart from that, there are sister diseases of asthma like allergic rhinitis. So sometimes patients present with cough, and you believe that it is a cough due to some other illness, but it is the postnasal drip that is happening, and it is the allergic rhinosinusitis that is actually troubling the patient rather than being asthma. So there are a few tests like pheno, sputum eosinophils, total eosinophil counts, spirometry, bronchodilator reversibility. So these are like a pack full of tests that can help you and guide you with the treatment. As well as there are people, there is especially in young females, there's this hyperventilation syndrome, anxiety disorder. So that also many times we mimic. As well as there are sometimes patients who are coming with like just a few days back, I had this patient with a mass, anterior mediastinum mass. So I actually thought, because she was like so young, I had the impression she must be suffering from asthma, but later on X-ray, it was found out that she was carrying this mediastinal widening. Later on, found out with anterior mediastinal mass. So there are like groups of diseases, array of disorders you need to keep in mind to know that this might be some other illness, or it might be a comorbidity that asthma might be like involving some other system, organ systems might be involved. And
Absolutely.
cardiac illness is definitely one other that is goes like in very close association with lung disorders.
Absolutely. So I think that fairly comprehensively covers everything that, I wanted you to talk about. And of course, one of the other very important things is, even if a person doesn't have COPD, it's very important to ask whether they are smoking or get exposed to smoke. That makes the asthma so difficult to control, even when it is true, pure asthma. But one of the biggest problems that we've always faced, and this is something that Dr. Modi highlighted when he spoke about contributing factors, the very first contributing factor that he mentioned, and probably the single most important thing, is adherence. So I'm going to go to Dr. Avya on this. Dr. Avya, lack of adherence is one of the main issues. So how do you check adherence, and how do you advise your patients to improve adherence to medication? What are the things you do?
So the most important question for today would be adherence. Now, whenever we have a patient who's not adherent, we often tend to blame the patient, but it's a contributory thing. We are equally to blame as much as the patient is concerned. Now, adherence is primarily because, lack of adherence is of three reasons. One is a medication-related issue, an intentional issue by the patient, and an unintentional issue. A medication-related issue can be a complex regimen, multiple inhalers, inhaler technique, time of onset of the inhaler, side effects, and more importantly, cost of therapy. The unintentional issues can be age-related factors, forgetfulness, and probable myths with respect to the inhaler. And the intentional factors can be denial, anger, or perception of well-being with respect to the illness. So the way to address all the factors is that let the patient counsel the patient with respect to the disease, make his primary healthcare giver as well as the patient understand the implications of the disease, the potential reversibility of the disease, and the importance of leading a normal life. The fact of dependency does not hold true in asthma is because you don't need water, you're not dependent on water, you need it to survive. Similarly, if you're an asthmatic, you need the inhaler as per the prescription, counseling them with respect to the side effects, telling them that it's absolutely safe, busting the myths with respect to the inhaled corticosteroids, telling them the bioavailability, explaining that this is a very minuscule dose, and at the same time having a cafeteria approach of the inhaler. So if the patient is comfortable with the inhaler he or she chooses, then the chances of adherence goes higher rather than we enforcing our belief on the patient. Also, at every visit, ensuring that there is a teach back method which is followed. Now, very often we understand that the patient cannot take the inhaler properly. So probably sending a video to the patient, having probably JRSP or breathe-free educator teaching the patient how to use the inhaler at home, and at every visit ensuring that the patient demonstrates the inhaler in front of us, and or if he forgets to get it, we have a demo piece, we teach him or her again. And we all see that the patient will have this expression if he's taking correctly or incorrectly. And we can judge that, yeah, okay, now he's got it right or she's got it right. So I think these are few ways in which we can assess this and understand the problem and address it, sir.
Absolutely. Excellent answer. I always think of it as three, you also spoke about a triad of things that you need to address. I always like to talk about primary adherence, non-adherence, where a patient doesn't take it at all. And that's, as you said, very often because of myths and cost issues and so on. The second is a secondary non-adherence, which is when the patient takes it, but doesn't take the doses you prescribe. So, I have an aunt who used to take 1/4 of any medication that was prescribed to her. So that's a secondary. And a tertiary non-adherence is they're following everything you did. They're taking it, all the doses you prescribed, but the technique is bad. And the third very often is a problem that is not picked up. And as you said, you have to get the patient to demonstrate in front of you. And I'll remind the audience that Dr. Lancelot Pinto has come out with this excellent, set of QR codes that the person just needs to scan, learn how to use the inhaler. The inhaler technique has got to that. Because in India, we have such a wide variety of inhaler devices. And of course, one of the other things is that try not to mix two different inhaler devices. One is confusing enough for a patient. Using more than one is extremely confusing. So you've heard how to improve adherence. And I think once you've got to good adherence, a lot of the so-called difficult to treat asthma is going to remain well controlled and not go into the area of severe asthma. So if we have made a definite diagnosis of asthma, which is severe, Dr. Modi, is it necessary to phenotype and endotype asthma? And if you do, what investigations do you need for these? Dr. Mahavir.
Thank you very much, sir. So I think phenotype and endotype, they are often, difficult to understand, but endotype is something what is happening at the pathobiological mechanism, what is happening at the cellular level or maybe the interleukins and the pheno levels. So, and phenotype is a observations or the trait or how the patient is presenting to us. So clinically, what we see is basically the phenotype, and what is happening inside the body, that is, I think, the endotype. So most of the times for severe asthmatic patients, as Gina also strongly recommends that the step 5 patient, those who are already on oral corticosteroids or on high dose of medications, and where their asthma is not getting controlled. So those category of patients will need to phenotype and endotype, and at least should not be starting from the first day of your practice. I think we all are doing eosinophil count as well as IG in the first visit itself, but that is just not for the phenotyping. I feel that is just for categorizing the patient, that whether they're actually allergic or whether there is something else. So that is not phenotyping. So phenotyping is, I think, only for the GINA step 5. And the common biomarkers, what I do along with the clinical history is, of course, eosinophil count. Although the levels up to more than 150 are significant, but I think in our country, 300 plus level is something what I take it as positive. Even IG level, although books say more than 100, I personally calculate more than 500 is something which is IG predominant. Then I also have Pheno in my clinic for last 2.5, 3 years, and it's an excellent tool because it can give you a lot of confidence about giving the dose of inhaled corticosteroids, convincing the patient, and then decreasing the ICS dose as the Pheno levels keep on. So that is also where we are using it, not for severe asthmatics, but even for mild moderate asthmatic patients also. And sputum eosinophils is something which has been talked a lot, but we are not doing it. But sputum eosinophils more than 2% again can categorize them as Th2 high asthma. So I think these are four basic biomarkers what we do. And along with this IG, if the IG level is very high, then the specific IG levels may be Aspergillus specific IG, or then I have certain kind of this CRD based IG levels, which can give you the IG of each and every allergen of specific IG level. So those are certain things which can definitely help us to phenotype and endotype our patients. And along with this, what is important is the history, because I think somebody who's having early onset asthma with a lot of allergies and maybe urticaria, migraines, so those kind of population, they are the one, and plus good family history. So they are the one, they may be basically IG mediated asthma, and they may have allergic rhinitis. But if you see the other part, there may be late onset, especially females, obese, they don't have any childhood history of asthma. They have typical late onset asthma. They may have nasal polyposis, and their Pheno values are very, very high. So these are the patients, they are basically maybe eosinophilic asthma. So I think these are two different ways by which I try to. And the third is the Th2 low or neutrophilic asthma, which is rare to find in the clinical practice. Maybe many of these patients are actually asthma COPD overlap, or they are basically behaving like COPD with very low eosinophilic inflammation. But again, we do have those category of patients, and difficult to capture on the first go. But if they have all markers, low IG level, low eosinophils, plus I mean, they don't have positive family history, and there is no allergic rhinitis symptoms, no nasal polyposis. So I think they are the one those who are basically Th2 low asthma. So that is how I normally try to categorize these patients.
Excellent. So I'll re-emphasize what Dr. Modi said. It starts with history, including family history. It goes on to a good physical examination, looking for things like rhinosinusitis, polyposis, looking at the skin of the patient, something that Dr. Nishita mentioned earlier, ask about GERD and examine for features of laryngopharyngeal reflux. All these come in before you start going to the lab tests. So I think most of your patients, you can pick up a lot of these issues by just doing a good history and physical examination. But I'm going to go to a question that Dr. Tridib Chatterjee, who always attends these programs and always asks good questions. By the way, there have been a lot of praise for your talk from listeners. I've been getting a lot of messages. He says, such an insightful presentation by Dr. Mahavir sir. And he asks, T2 asthma seems to be like ACOS. I assume he means T2 low asthma. Th2 low asthma seems like ACOS. What's your comment? Because Dr. Nishita also mentioned the increasing overlap between asthma and COPD.
Yeah, so I think T2 low asthma is something which is behaving like asthma COPD overlap. That is very rightly said, because many of these patients are actually having more of airway remodeling, which has happened completely, and they have developed maybe a persistent kind of airflow limitation. There may not be that much of reversibility. So in a way, I mean, COPD patients or ACOS patients, they are the ones those who are T2 low asthma. So I agree with this.
Thank you. So, by the way, all panelists, please feel free to come in on any question. It's not only to the person I address the question to. If you want something to be added, you're welcome to make comments. You're welcome to contradict what has just been said. I'd like to keep this as interactive as possible between the panel. And I'd like to take a lot of questions from the audience also. And there are a lot of questions are coming in. So we'll come to them gradually. I'm going to go to Dr. Thomas on this. We have made a diagnosis of severe asthma. We've ruled out all the other conditions, the masqueraders, the mimics. We've ensured adherence. Now we made a diagnosis of severe asthma. And the patient asks, what is my future? I have severe asthma. What is my future? So how do you prognosticate patients with severe asthma, Dr. Thomas?
Well, I think as far as prognostication of severe asthma is concerned, I think it all depends upon the other things that we talked about here, the so-called comorbids and the rest of those things that we talked about. In spite of this, if you want to put a put a stamp on this and tell him that this is your pulmonary function. For example, I often talk about lung age, for example, patients. If you're going to be non-compliant with treatment, this is your lung age, this is your age, and this is your lung age. So I think that's a very easy way of making people understand that their lungs are not functioning as well as they should. So I think the question of prognosticating this, I think, is not an easy thing to do. But I think we need to look at the finer stuff, like I would think something like a 6-minute walk distance, and then give him the therapy and ask him to go back and redo the 6-minute walk distance, because people understand figures more than synonyms that we talk about as such. And numbers games are much better because they understand it much better. So I think I would look at a dynamic test like a 6-minute walk distance to really look at and prognosticate the asthma over a period of time, given the type of therapy that we have. And probably, I think, introduce them to the fact that there is this entity called Biologics that you can go to at a certain point in time. So you prepare them. Biologics are not done overnight, but you need to prepare them for that, both mentally, physically, and financially. And then you really get into that circle of biologics.
Great answer. But do you do this at first sitting, or do you wait for a few months with
I
full
would
treatment?
think that I won't frighten him with the biologics on visit 1. I would rather sit back and hold it and do the simpler things first, prognosticate his problem. Probably, I think I would really rely to a great extent on the 6-minute walk. I'm a great admirer of the 6-minute walk because I think it gives a great feeling both to the doctor and to the patient as such. The question of response to treatment. So I think it's very important to prognosticate that. But I would think this question of biologics, I just said it for completion's sake, in the sense that you need to complete this at some point of time, probably not at visit 1, but somewhere down the line.
No, I was talking about when you prognosticate, because this is asthma. We hope it'll reverse.
I would think that we need to prognosticate as early as possible and try and communicate this to patients. And I think sometimes that prognostication itself would not be possible on visit 1. It may be a little too early to do it on visit 1, or we may be jumping the gun here in this situation. So I think the best thing would be to sort of convince yourself that this is what you're looking at. This is what you want to expect over the next couple of months, or couple of months, for example, couple of months or weeks. And then I think you try and prognosticate patients. Prognostication will help the question of adherence to treatment, will help compliance to treatment, and help patients understand the real problems that they have and the reason why they need to treat them. We ask them to treat yourselves, but why do you need to treat yourself? And I think that's really what is important. I think we need to get this message right across the table.
Absolutely. Excellent. Dr. Pratibha, my next question goes to you. You have a patient who's on high-dose inhaled steroids and on a LABA with lack of control. Patient is still uncontrolled. Now, under what circumstances would you add another drug, and what drug would you consider adding? So patient already on high-dose ICS and LABA. Dr. Pratibha, you're muted. Can you unmute, please?
I said this is giving us a very nice flow of discussions. Again, taking the lead from Dr. Thomas, the basics first. So even if the patient is on high dose of ICS and LABA along with it, so we'll go back to the basics and again see that everything is in the right place, starting from the diagnosis, ensuring the diagnosis, again, the rest of the things that we have been talking, inhaler techniques, adherence, contributory factors and all. And still, if everything is okay and still the patient is having this uncontrolled asthma, so again, the crux of the talk that Dr. Mahavir is given is we will come to the phenotyping. So ideally, this is a point we should be able to phenotype the patient, and we should start thinking of biologics, and we should start talking about the biologics with the patient. But again, as even in India, in the current scenario, as biologics are not as, availability and affordability are two basic issues that we deal with. So we'll try to add on something more, which will be the biologic component that can be added to the treatment. And even if it is TH2 high kind of asthma phenotype or TH2 low, I think in both we can add LAMA is the first kind of thing that we can add, because the ICS is already high dose ICS we have given. And then again, there's some evidence of low dose azithromycin that, can help in certain patients, certain subset of patients. And again, if biologics, we cannot now think of biologics, we can add a little bit of oral corticosteroids. Again, very, very kind of, being very kind of ensuring that, the least kind of side effects are implicated for these patients. But in this scenario, and if we have done all this, or, if it's a Th2 high phenotype in which, biologics, we have the targeted biologic therapy for such patients, this is the time we start kind of, discussing that with the patient. And if, everything is appropriate and we are able to the patient is able to fit in the right eligibility criteria for the different biologics, and the affordability thing is there, then we can offer the biologic treatment to these patients.
Great, thank you. That's such an important part of our practice when you add on what. So I'm going to again, kind of extend the question to Dr. Nishita. So Dr. Nishita, which is preferable? Do you want to further increase the dose of ICS, or would you rather at a medium dose itself of ICS add on a drug like a leukotriene receptor antagonist, montelukast is what we have, or do you add an LAMA? Which would you prefer? And do you decide based on an individual patient? This patient, I'm going to add on a LAMA. That patient, I'm going to add on an leukotriene receptor antagonist. Or a third patient, I'm just going to bump up their steroids, inhaled corticosteroids more. How do you take these decisions?
So basically, the decision to decide whether to increase the dose of ICS or to add leukotriene receptor antagonist or LAMAs. So that depends on several factors, depending on what kind of patient we are interacting with. So we have got like 3 molecules with us. At one end, we have got the inhaled corticosteroids. So there are quite a good points about inhaled corticosteroids that they are like the most potent bronchodilators. So if we are increasing the dose, then that is why the patient symptomatically will feel much better about it. As well as there is also one advantage of giving high dose ICS is that the monotherapy can be given to the patient. But on the other side, the disadvantage with inhaled ICS, as we all know and we encounter in our daily OPD also, the oral thrush and the dysphonia that the patients suffer from. As well as there's this plateau syndrome that in which the higher dose of ICS is not working really well with the patients. So the symptoms are not getting relieved as much as we expect to with the low doses. So these are like the clinical things that we need to be aware of while we think of increasing the dose of ICS. Now, the second molecule, if we talk about leukotriene receptor antagonist, so this is one drug which is like quite popular amongst the patients, and it is very much kind of a favorite among patients also because it comes in tablet form. So it is very socially acceptable. And as well as the patients who are suffering from allergic rhinitis. So in comorbid conditions like allergic rhinitis or exercise-induced asthma, aspirin-exacerbated asthma. So in all these conditions, this is a favorable molecule that works wonders. But the cons of, again, this combination of leukotriene receptor antagonist is one that Gina has also warned everyone regarding the neuropsychiatric effect. That is the cognitive impairment that happens with it. As well as it is less potent than high dose, increasing the dose of ICS. And the third molecule, that is the LAMAs. So LAMAs, tiotropium, we have got glycopyrronium. So they have got this advantage of giving once daily. So you can combine it with the ICS, and the potency is also very good. So they act as like an additional bronchodilator effect. But again, they have got their side effects of urinary retention and dryness of mouth. So there are like 2 sides of coins on each and every molecule. So the clinician has to take into account the guidelines, thoroughly know that what is written according to the Indian as well as the international guidelines, and to see what the clinical scenario is of the patient and decide accordingly what is the best combination. But generally, according to Gina, it is proposed that if the patient is not responding to low to moderate dose of ICS, then that patient is supposed to be given LABAs. And if after adding LABA also the patient is not responding, then that patient needs to be added on to LAMA. LAMA needs to be added. So that is what Gina tells us, and the decision is up to the clinician who's handling the patients.
Absolutely. And in concert with the patient, we consult the patient and we decide on, would you rather add on another inhaler or take a tablet? Because finally, that's, going to be what decides adherence or not. So it's a joint discussion between them. But I know that, the FDA and GINA have highlighted the black box warnings on montelukast. I want to ask you for your personal opinion, and I'm going to start with Dr. Thomas because he's usually the most forthright on these things. Dr. Thomas, have you had a problem with montelukast ever?
Zero.
Yeah. Anyone else has seen problems, suicidal ideation? And so I'd be very cautious about using it in very young children, of course, and I don't treat young children, but I've never had a problem with adults. Anybody here? Dr. Pratibha, Dr. Nishita, Dr. Mahavir, Ravya? No one at all.
Yeah.
So
I'm not like really sure because the patients of who are having long-term asthma, they come to in the OPD, they come to us with sense of depression. I don't know that is because of the pharmaceutical drug that they are taking, or it is because of the associated illness that they are suffering from. So it is hard to decide.
So I can tell you, we did a study in around about 2000 or 2001, where we did a study of anxiety and depression in patients with asthma and COPD. And about 45% of them had anxiety, depression features. And this is well before we started using montelukast. So it is a feature of any chronic respiratory illness. And to attribute it to montelukast is, I think, a stretch. So, but I would advise caution, of course. It's been highlighted. Let's not ignore it. But let's not also get too frightened of using a drug, which is, as you said, not very potent, but is socially acceptable. You use the right term, socially acceptable. So
patients are on montelukast for years together, sir. And the minute we prescribe them an inhaler, they get depression at that point of time rather than the montelukast.
Maybe the combination of montelukast along with this antihistaminic, which is used commonly. So I think they are the one where the patients, they may be getting more lethargic, and then the daytime symptoms also may be there. So it may not be the montelukast, but the antihistamine which is added along with this.
Absolutely. And I think that's especially true of young children. Long-term use of an antihistaminic is known to produce cognitive decline. So I think that's the greater problem. We should get the patient off an antihistaminic as soon as possible.
But definitely we need more clarity on this subject, right? More studies have to come here. Yeah.
Absolutely. Absolutely. Dr. Avya, we've known about small airways disease for a very long time. But I think, especially with the advent of impulse oscillometry or forced oscillometric techniques, we become even more aware of this and picking it up more often. So do you think it's always important to look for small airways disease? And how do you diagnose it in that case? And if you make a diagnosis, do you think extra fine particle inhalers are better in their management?
So, as far as small airways are concerned, when we have an asthmatic, depending on the severity of the asthma, we do have some amount of small airway involvement in them as well. And typically on a basic spirometry, the ME of 25 to 75 gives us some idea. Now, suppose we have a patient but our treatment is not going to change. We're still going to prescribe the patient an ICS formoterol-based regimen based on his symptoms and sometimes maybe on his FEV1 readings or not. When we have a patient who's having a normal spirometry and is complaining of symptoms, at that point of time, I would be tempted to probably do his lung volumes and see if there is any air trapping at that point of time and advise an impulse oscillometry as well. Because more often than not, when we label our patients as cough variant asthmas, we tend to ignore the small airway involvement, as cough may be the only presenting feature in small airway involvement. So if there is an isolated small airway involvement, which is proven on an impulse oscillometry, there is air trapping, there is an MEF 25 to 75, which is low, in a young adult exposed to allergens. I would say a young adult exposed to allergen because if there is a chronic exposure to these noxious products, eventually it would end up in being a COPD rather than an asthmatic. So a young adult with a small airway involvement, I would put the patient on extra fine particles provided the large airways are normal. If there is large airway involvement, the ICS formoterol works equally well in the entire airways combined. So depending whether it is isolated small airway involvement in a young allergy exposed individual, or it is a large and a small airway involvement, will define whether I use only extra fine particle formoterol-based combination or an ICS formoterol-based combination.
Excellent. I would completely agree with you on that. And I think another avenue in which we pick up small airways disease sometimes is when a patient comes to you having had a CT coronary angiogram for breathlessness, and there you see a lot of evidence of small airways disease. So that's another avenue in which we can pick it up and move to treatment of that. Dr. Mahavir, you already spoke about the cutoffs that you use for eosinophils and IgE levels in India. And these are slightly different from the West. Why do you think this is? And should we use local cutoffs? And how do we arrive at these cutoffs for India?
Yeah, I would like to know from you only actually, because it's always often asked question and we get confused. But I feel more than 300 is something what I use it as a cutoff for total eosinophil count, because many of the patients, because of the helminthic infections what we have common in our country, so because of that 150 200 is something what we get very often. And very important in all these patients is to see their maybe historical reports of eosinophil count, because most of the time these patients are already on inhaled corticosteroids, they have received some bursts of oral steroids, and then their eosinophil count becomes absolutely maybe 1 or 2%. So always, even the first report, if you just go back to the file of the patient and find out, so that is the one which can give you an exact idea about the eosinophil count. And the total IG, although many of the times we feel that it doesn't take us anywhere, but still the values in the West, they say more than even 30 or even more than 100 are significant in the West. But over here, I feel many of the patients, those who have IG levels of more than 300 or even more than 500, they are the one where I consider them as typical IG mediated asthma. Because I think our values are different, because maybe we are getting exposed to dust mites, pollution, pollen grains very often as compared to the Western population. So that may be the reason that our cutoffs are different as compared to the Western cutoffs. But I would like to know from you as well as everyone that what cutoff we should be actually using. And sometimes we tend to get very high IG levels, maybe in thousands, and then the patients are not actually symptomatic. And sometimes we have this eosinophil count which is 10% and plus IG level which is also at 5,000. So I mean, then it becomes very difficult to phenotype that particular individual.
I'm going to go to Dr. Thomas on the same question. Dr. Thomas, you and I have seen a variety of eosinophil counts over the last 25, 30 years. Do you get a sense that the levels are actually coming down in the general population?
Yes.
No, I think just one comment on the eosinophil I'd like to make. I think if there's one cell that's been bashed around and battled around all over the place, footballed around if you want, or whatever you want to say, it is the eosinophil. And I think guy is still surviving, and I find it very, very difficult to understand that this guy is still surviving in spite of all the bashing that he's getting. But we need to understand that in a country like ours, with so much of infection, so much of helminthic infection, so much of filariasis, so much of tuberculosis, so much of viral infections, repeated infections, the question of the eosinophil itself comes into question. I would be very skeptical about using eosinophilia in singularity when I look at the biomarkers as such. I would be really skeptical about it. I would rather put the whole thing in a box, get the whole thing, get the biologics, get the eosinophil, get the pheno, get what are the markers I want in a box, and make a boxy decision rather than base my decision on one single eosinophil, which I think is a sort of battered box altogether.
Absolutely. And that goes back to what Dr. Modi was saying. Go into the past records, see
exactly.
if it has been
I think that's wonderful.
And I always use these as soft supports, not as hard supports. As you said, IgE high or eosinophil high, that itself makes a diagnosis. Definitely not. Dr. Nishita, do you have any experience at Asthma Bhavan at looking at eosinophil counts in the general population? I know you all are doing a lot of research work in this area.
Total eosinophil counts, till now we have not done any research regarding the eosinophil counts, but we are definitely doing the sputum eosinophils of the patients. So I think that is a very specific marker and much more useful with regard to checking whether the patient is responding to the treatment, as well as in the ABPA patients also. We are doing that.
I'll just add, like, this latest kind of a consensus statement, which has been, Rajadhar has kind of published, where all the experts, Indian experts, have come together to see the cutoff values, and whatever studies we have from Indian, context, they say that still we are almost, it's almost similar to the Western cutoff levels.
Exactly.
Of, that we have more of parasitic infections or helminthic infections. And I think if you just look more in a common sense way, it's all comes to the clinical correlation. So it is just not like, separately we are looking at IgE or eosinophils, but if it is actually a kind of difficult to treat asthma and or severe asthma, and then there are like, eosinophils, IgE levels are high, so then we may have to give it that much importance. So more
Absolutely.
of it comes to the clinical, correlation of this values.
Yeah.
Also, sir,
And-
can I add something that over
Yes, please.
over the last 30 years, there has been a significant improvement in health and sanitation in our country. So that has to attribute to the fact that we can't just keep calling parasitic infections the sole reason for high eosinophil. We've all taken albendazole tablets and DEC tablets in medical college and in school for years and years together. That ought to have some amount of herd immunity for the eosinophil, as Thomas sir would say, that we should stop bashing it because of the helminthic and parasitic infections.
Absolutely. In fact, I remember as an intern handling at least 4 or 5 patients with hemoglobins of 3 and 4 grams because of, hookworm infestation. By the time I finished my post-graduation, we were seeing far less. And when I became a clinician, a consultant, I've not seen that kind of hookworm-associated anemia to that extent. If I see an anemia of 3-4 grams, I know it's a hematological malignancy. That's the problem, or the person has bled horribly somewhere. So those days, because as you said, Dr. Avia, of better sanitation, wider use of antihelminthics, those days are gone. And I think that's why Raja has shown that our values are very similar, as Dr. Pratibha was telling you, to what the West has. So I think those cutoffs are going to change. But remember that India is such a varied country, that we don't have one India. We have an urban India, a rural India. And I think we need to adjust for those when we interpret these values. I'm going to go back to Dr. Thomas on this. Dr. Thomas, Dr. Modi told us about the biologicals, anti-IgE, the IL-5 antagonists, which are available to us. How do you choose between these? Are there any criteria you use to choose between anti-IL-5 agents and anti-IgE agents?
No, I think if you have a lot of atopy and allergy, the anti-IgE comes and drops itself in automatically. There's no doubt about it. Especially the younger individual today, the atopic individual, the younger asthmatic that we look at, coexisting allergic rhinitis and rhinosinusitis, I think are a classic marker for the use of omalizumab. And I think we've had enough and more experience with omalizumab to be sure that this is going to work at this sort of level. The other MABs, especially the IL-5, the other 2 IL-5s as such, both Mepoli and Benrali, I think are more for the slightly older onset eosinophilic asthmatic who is now not controlled and who has all the other problems rolled into one. And in spite of the best medical treatment and the best compliance and the best look at comorbids, it still remains uncontrolled. It's like going to the mountain and then hitting the mountain and then coming back again. You're bouncing your thing for and again. So I think it becomes a little difficult at this point of time. That's where I would really consider biologics. And the question of triple drug therapy, I think, has put in more confusion into my mind about when do I get to biologics as such? Do I need to squeeze the triple drug somewhere in the middle? I think I should, because I need to give him a chance with the triple and then see, okay, he's done well or he's failed or he's not doing well before I move to the biologics. So I think the triple has created a space for itself at this point of time. And I think we need to go through the triple to get to the biologics.
Absolutely. Completely agree with you. I like to think of it with a graph that I saw some time ago, which put people into 4 categories. On the x-axis, you had the IgE levels, and on the y-axis, you had either the blood or the sputum eosinophils. And really, I think Dr. Nishita told us that sputum eosinophilia is a better marker, but we all don't have access to it. I think one on the east Dr. Dasgupta, Angera Dasgupta, and one on the West, Asthma Bhavan, Dr. Nishita, you all are doing sputum eosinophils. Very difficult to get a good quality sputum eosinophil. So I use blood eosinophils. So I assume that's on the y-axis. If you have a high IgE level and a normal eosinophil level, omalizumab. If you have a normal IgE level but a high eosinophil level, the anti-IL-5. When both are high, then you can use either. And as you said, first omalizumab, then the the anti-IL-5 agents come in. And if none of these are present, then you have that group that Dr. Modi told us about, where these are the older, more obese women, the smokers, who don't respond to any of these biologicals. For them, you try the azithromycin, or you try weight reduction, which nowadays is being done very successfully. We have a lot of good weight-reducing agents, oral. And of course, you get them to stop smoking if they've been smoking. And bronchial thermoplasty is now only, a line in a book, because we can't do it any longer. I hope it comes back at some point, because I think it did have a role. So that's how I position my patients for biologics, which biologic to use. And as I said earlier, please feel free to come in on any one of these, all of you. But I'm going to go to Dr. Pratibha. How do you decide the dose of omalizumab? And having given it, how do you decide response to the treatment?
So omalizumab actually is like one of the first biologics we have, and I think most of us have used it. Though still, the kind of so it is, the dose is primarily defined by the pre-treatment levels of the serum IgE in the patients, and also the weight of the patient. And most of the drugs that we use, like Xolair, and they come with their own table kind of a thing, which help us to kind of or it's a kind of a tool which help us to define the dose for the patient, which can be given like from 75 mg to 600 mg, maybe twice a month, like every 2 weeks or every 4 weeks. So once we have decided the dose, and if the dose is more and of the IgE level is more, so it can be given even every 2 weeks subcutaneously. And how do we define the responses? Like usually, it takes like 4 months. They say that we have to just kind of, observe the patient for 4 months before we come to any conclusion that the patient, has the response to omalizumab. It is usually defined by, again, as Dr. Thomas said, is that patient satisfaction is the first and the foremost thing that comes, which is like, it encompasses basically everything, which will be the control of the symptoms and decrease in the use of the relievers, and exacerbations decrease, and the quality of life increases. So all of these things, like when you kind of follow up with them, so you are able to understand that the patient is being responsive. And you usually give it a trial of like 6 to 12 months before you actually make any kind of ultimate conclusion on the effect of omalizumab.
Great. And the last point you made about not just waiting for 4 months, but also waiting for a whole year. Dr. Deepak Talwar came out with an excellent example of a doctor he was treating from UP, who came back after 4 months and said he's feeling wonderful. But 12 months later, he was back again with the same problems, though he continued the medication. And they realized that he was having a seasonal worsening. So you've got to see them through all the seasons. Absolutely. Yeah. So they can have an exacerbation, and you'll attribute it to the drug that you've given. Absolutely. So that's why I think you've got to wait a longer time. So you can wait 4 months to assess how effective it is and continue with it, but don't give up on it too soon. Also, so use it, don't give up too soon. But if it's not been effective in about 4 months, 5 months, it's probably not going to work. And that's when you have to decide, and I'm coming to this with Dr. Nishita, when would you consider shifting to a different biological? And, are there any examples of which one to shift to when you've started with one? How do you shift to another?
So basically, when we are planning to shift a patient, that depends on how much response the patient is getting from the biological. So as Dr. Pratibha has earlier mentioned only, so till 4 months, the patient generally starts responding that, yes, we are feeling really well. The asthma control questionnaire also improves in the patients, as well as generally patients want to get the repeat testing done also. But even if the patient is not responding well, or you are feeling that the phenotyping is not matching exactly with the biological, and you later realize that he might be matching with some other biological, or if the cost is an issue with the patient that, for example, benralizumab, later on he thinks that I cannot carry on later with this drug, then there can be an issue with the frequency of the medication also. Like benralizumab is popular for being the least frequent of the agents. So that is one thing, that these are like the factors that can make you decide on to changing the biological. And for the various biologicals of and giving the examples regarding what biological to shift to and which biological to shift from. So basically, we have only handful of biologicals present in India right now. One of them, and the most oldest, is the omalizumab. So if there is this patient who's having eosinophilic type of asthma, who has got raised eosinophil levels, and we are on omalizumab, then we can like switch this patient to benralizumab or IL-5 antagonist like mepolizumab. In a similar vice versa situation, if the patient is on benralizumab and we later find out that he's more towards the allergy-driven asthma side, as well as his skin prick test is positive, then and his IG levels are raised, then we can switch to omalizumab. And with mepolizumab and benralizumab, basically the frequency is the thing that needs to be taken care of. And the dupilumab, it is not presently available. It is still, clinical trials are being run, but it is available for the atopic dermatitis. And generally, for the patients who are having nasal polyposis, chronic rhinosinusitis, atopic dermatitis, these are the candidates in which dupilumab is working wonders. And the clinical trials are showing like really wonderful results of dupilumab. So these are the biologicals we can like play with, and we can change them. But generally speaking, once the patients actually start taking biologicals, then they see such wonderful improvement in their symptoms that they actually don't want to change their drug. So because this is admirable, because if you like work and train, and initially you put on your work and you like decide what all agent is fitting the patient, then that agent generally works fine for the patient.
Yeah, and I think one of the other things is many of these patients are on steroids when they come to you and you have to take this decision. So you cannot completely rely on their eosinophil counts or their IG levels. Those are going to be modified. So sometimes you have to make this leap of faith and say, I think this person is going to become better with the biological. I'm going to give it a trial, provided, of course, he or she can afford it. But all biologicals potentially, all drugs potentially have side effects. So, Dr. Avia, specifically, what are the potential side effects of the biologicals?
Most common side effect which we all look for is a hypersensitivity reaction, which can manifest in any way, right from a skin rash to vocal cord edema to a flare-up of the asthma itself because of inflammation in the lungs. Having used biologics in about 6 patients and had the privilege of using dupilumab in one patient as well, he was an elderly gentleman. We sourced it from London, a 40 patient. The 1 year he was on dupilumab, his inhaled corticosteroids came down. We couldn't give him oral steroids because of GI ulcers. He passed away because of non-respiratory complications and had the best year for respiratory issues. So it's a wonderful drug, like Madam said. Hypersensitivity is known, but I have not encountered any patient with a hypersensitivity reaction. I attributed the incidence to the same as we take a vaccine and we develop a vaccine site reaction. It's that common. If administered correctly, the chances are extremely rare. There are indications that there can be a flare-up of herpes zoster, and there can be a flare-up of certain parasitic infections because we are targeting the eosinophils. The data is scarce because the number of biologic patients in our country is, I would say, less than 5,000 combined from north to south, east to west. So I think we need more Indian data and Indian perspective to understand what are the side effects. But yes, I've personally never encountered an anaphylactic reaction or had any of my colleagues report one. Never had any of my colleagues discontinue a drug because of a potential side effect. So I personally feel they're extremely safe, and minor aches and pains are part and parcel, and patients do well once they're counseled that this can happen.
Absolutely. And some of the times we see side effects, it's because the steroids are being withdrawn and they're actually getting steroid withdrawal effects rather than the effect of these drugs, though it's tempting to blame the new drug that you put the patient on. That was an excellent answer. Dr. Avia, did you mention once that you make sure that you give the drugs, the injections yourself or under your supervision in your hospital?
The first dose is under supervision in the hospital itself, either in the emergency or in the ICU. So we've had patients who've been reluctant to get admitted for the first dose. So we give them in the emergency department and observe them for about 4 to 6 hours and ask them to leave. And subsequent injections are administered at home by a qualified nurse.
Great. We have about 20 minutes, and I'd like to take some audience questions. So I'm going to go very rapidly through the others. Dr. Mahavir, I'm going to skip the next question to you, which was on choosing between Nepoli and benralizumab. Unless you want to say something specific about that. How do you decide on success and failure between these two drugs?
No, I think benralizumab has complete depletion of the eosinophils. So basically, there will be complete blockage of this IL-5. So maybe it is for patients those who have very severe eosinophilic asthma. So the studies have shown that at certain point of time, this complete depletion of eosinophils may be useful in certain subset of patients. So that is one thing. I think the basic comparison between these two drugs is the cost. And second thing is, of course, the duration, because the benralizumab has first 3 dosages once a month, and then you have once in 2 months. So if you have a patient who's coming from far distance, then I think their benralizumab can definitely be given an advantage because the patient has to come once in 2 months. Otherwise, both the drugs go hand in hand, although there are anecdotal reports where one drug is better than the other. And if you shift from one biologic to the another, then from Mepo to benralizumab, then the patient seems to be working better. One more advantage of benralizumab is I think it has more effectivity in patients, those who have more mucus hypersecretion. So those category of patients where benralizumab is supposed to have better result as compared to nepolizumab. So otherwise, I think both can be equivalent.
And the two that we don't have, Dr. Thomas, dupilumab and tezepelumab. You know, I must appreciate all our panelists and speakers because they've been pronouncing these tongue twisters with such ease. And I get into tongue twists every time when I say tezepelumab. So I think over time I learned to say it. But Dr. Thomas, how would you position these two molecules?
No, I think tezepelumab is very, very interesting in the sense that you're tackling it right up front itself. It's like an opening batsman scoring 100 in a T20 match. There's no question. You're going to win. That's what it is. So I think that's the way that I would look at that drug right now, because the TSLP is right up in front. And I think the whole cascade of events, cascade of the drugs that you're going to be using down the line is going to be totally reduced. There's no question about it. I'm with all excitement waiting for this drug to really walk in to try and see whether we can have indiscriminate use, as they say. No, they use the word indiscriminate, which I think is a little indiscriminate by itself. So that's really what this is all about. So whatever said and done, it is quite exciting.
Yeah.
So it's something like, sorry, so just to add, it's going to be like a broad spectrum antibiotic of biologics. So the meropenem of biologics. So wherever, whenever you can use it. Yeah. So yeah, it is prone to misuse. Yeah.
Absolutely. And my other worry is when you go so far upstream, is it going to block some beneficial effects also? That's the big worry.
Correct.
But I think Dr. Modi made an excellent statement. He said you may even think of stopping phenotyping if you get tezepelumab. Yeah. Dr. Avia, go ahead, please. Yeah.
We've got new data coming in that dupilumab works well in COPD as well. So we may eventually stop phenotyping, and more often than not in tertiary care centers, we have airway remodeled asthmatics who actually present like COPD patients with air trapping and no reversibility on the PFT, and we are stuck sometimes. So then we tend to engrave the history, keep digging, and find that one family history of asthma and some exposure in the childhood and label them as asthmatics rather than a groupie COPD. So for them, dupilumab would eventually be a no-brainer. Or obstructive airway disease, severe, consider dupilumab.
And actually, if you look at the cascade, tezepelumab may also work the same way. So I think we're all excitedly waiting for this, but with a sense of caution, of course. And whenever we talk about biologics, the first thing that comes to mind is how expensive it is, how many patients can afford it, are they happy about taking it forever? Anecdotal experience suggests that patients are very happy to continue and they're willing to pay that extra little amount. But, at any point, if we have to stop biologics or reduce dose frequency, how do you do it? What are the likely consequences, Dr. Pratibha, of reducing or stopping the biologics?
So this is, I think, it's a very gray zone. I mean, there's a lot of debates on that. So a couple of studies, which have just, I think 1 or 2 studies we have. One is like the COMET study, which was like, where they have compared like stopping it or continuing the long-term use of MAPLE and omalizumab. And what has been found is that stopping actually leads to increase in exacerbations and decrease of quality of life. Now, this is again, what I will say, it's still $1 million question for both the physicians and the patients. So what is the end point of biologics? It's very difficult. So I don't know, to be honest, like all of your experiences that patients love them, they keep on using them, and as if the cost is not an issue. But on our side, I think the only patients who don't question it is the CGHS patients or the, patients who have some way of getting this thing. But otherwise, who is spending out of their pocket, you have to answer how long. So yeah, it is like, it's still, I think, more kind of, experience and more data is required in this, that should be the end point where we can call it a day. But otherwise, as I said, and there was another study which was done basically for omalizumab. And in that, after reducing the kind of, when we were like weaning it off, there was certain like 22% of patients who were still doing okay on decreasing the dose of omalizumab. But
Exactly.
that is how much, literature just tell us about.
Yeah, and that's been my experience also. Few patients, you can get them under very good control and then manage them with lower doses of inhaled corticosteroids.
Yeah.
They will have a few symptoms, but they're willing to live with those symptoms because they just can't afford, the more expensive drugs. So, yeah, so I think it's got to be decided on an individual basis. But I think equally important, we should give it a fair trial and not stop too soon.
Yeah.
Last few questions before we go to the audience. Dr. Nishita, is there a role for surgery or a procedure in severe asthma? When do you consider it, and what is its current status? Sorry, go ahead, please.
So basically, the only non-pharmaceutical treatment that was available was bronchial thermoplasty. So, bronchial thermoplasty was introduced in our country by Boston Scientific. A layered system was introduced, and it became, so they held quite a few workshops throughout the country also. But unfortunately, because of many reasons, they had to withdraw from India. And Gina also then advocated that it is just to be given in clinical trials or to be used for research purposes. So basically, the point with bronchial thermoplasty was it was targeting neutrophilic asthma patients. So that is a very small segment of the population, and it was very difficult to look out for those asthma patients in the entire gamut of asthma OPD. Because major chunk is always constituted by the allergic group or the eosinophilic group. Neutrophilic is very hard to find. So that population, that was one of the reasons why while it was there in India, then it could not become very popular because the proper phenotyping and the proper patient that could get good result out of bronchial thermoplasty was very difficult to find. And that is why, as well as the short-term morbidity issue was also with the patients that you did bronchial thermoplasty and just after that I got this exacerbation. So they were like correlating, they were not able to correlate the long-term effectiveness of bronchial thermoplasty. The short-term morbidity overshadowed the long-term benefit of thermoplasty.
Controversially, I'm going to ask you, suppose you have a very obese asthmatic, would you advise them to go for bariatric surgery?
I believe so, but first always the other non-surgical methods, I will always advise him for that, because like bariatric surgery is not like the remedy, the total treatment, and it is also associated with lots of side effects.
So for its own benefit of reducing weight, you can do it, but certainly not yet. There is no recommendation to use it for somebody for control of asthma. I think that's very important. I'm going to come to this question that Dr. Arnab has asked. What is the role of immunotherapy in the treatment of difficult to treat asthma? I'm going to go to Dr. Avia on this. Things like subcutaneous or sublingual immunotherapy. Dr. Avia, what is their role? Have we lost Dr. Avia? Yeah, I think so. This seems to have got cut off. We'll come back to that. Would anybody like to add? Is there a role for subcutaneous or sublingual immunotherapy? Dr. Mahavir, would you?
I can
Dr. Ishla, go ahead, please.
So basically, sublingual and subcutaneous immunotherapy, they have the role when the patients are SPT positive, they have allergic history, and especially it has got wonderful results with the patients who are showing house dust mite positivity or venom. They are venom allergic to venom, like honeybee venom or some insect venom. So in that, there is good effective results.
Yeah, and of course, it's important that the patient should have a fairly well-preserved FEV1. You don't want to try it in somebody who's down in the boots as far as FEV1 goes. But in the latest guidelines, they've extended its use across. Earlier, it was only in, I think, step 5, and now they've extended it into the other groups, which I think was a long time coming, and it is actually very useful.
But unfortunately for India, we do not have standardized allergens as well as the immunotherapy agents also. They are not standardized. So
Absolutely.
the effectiveness is very questionable.
And that's true even for the skin prick tests that we do. You know, very often things are not properly standardized. I'm going to go to the audience questions at this point. Since you brought this up, Dr. Mahavir, how useful is Pheno in assessing response to biologics? And what do you do if Pheno is not possible?
Yeah, so Pheno, as I said, that it's basically exhaled nitric oxide, and it gives you the level of inflammation, eosinophilic inflammation inside the airways. So it's a wonderful tool, especially to find out if the patient is going to be responsive to inhaled corticosteroids. So I use it in my practice to boost the response or the adherence to therapy, because suppose initially the Pheno level, if it is 25-30, and if the patient is on inhaled corticosteroid, after 2 months of therapy or 3 months of therapy, the patient's symptoms are practically, they may say that, no, I am not that well, but if the Pheno level is coming down, but then that time we can definitely say that, see, now I'm going to decrease the dose of inhaled corticosteroids because your inflammation inside the body because of medications is low. So it can be used to improve the adherence. Second thing is to categorize the patient, especially if the Pheno levels are very high, and if these patients have nasal polyposis. So these are adult onset asthmatic patients. So they are the those where we can say that the IL-5 antagonists are going to work better as compared to the anti-IgE therapy. And if Pheno is not available, I think there are studies which have shown that the eosinophil count in the blood, absolute eosinophil count, and the Pheno values, they do match. Okay, except for the patient, those who are smokers. Otherwise, in most of the patients, the absolute eosinophil count and the Pheno values do match. So it may not be available at all the centers. So, but still we can use it based upon the judgment of eosinophil count.
So definitely useful, but needs to be handled with caution. And where available, I think we should use it more often. I feel sad that it's not given its right place in asthma management. Going on to another question on something we discussed briefly earlier, but Dr. Rohan and Dr. Jatin are going to club their questions. They ask, what is the role of azithromycin in severe asthma? Should we give this to all patients of severe asthma before trying biologics? And Dr. Jatin adds on to that, between azithro and clarithrol, which to use, which is better, what dose and what duration would you give either azithro or clarithrol? Whom do I go to with on this? Dr. Pratibha, will you take that?
Okay, so So the question is, before we start biologics, shall we be again, giving the trial of the azithro? So I think again, this will come to the phenotyping, and when it is a Th2 high kind of an asthma phenotype in which we have the targeted therapy, we should kind of, ideally like give an option of biologics to the patient. But in the polygranulocytic inflammation or Th2 low inflammation, there the role of low dose azithromycin is still there. So after trying to add LAMA and other leukotriene receptor antagonists, so azithromycin can be tried in these patients. And most of the studies are with azithro rather than with clarithrol. So mostly, whatever recommendations are for azithro only, which is 500 mg like thrice a week, is usually given. But again, it has to be given with a lot of precautions. And we have to go through, it can lead to ST prolongation. So the ECG of the patient has to be, kind of monitored when we are giving these patients. And then again, there's risk of kind of, there is like, azithromycin tolerance can develop. So though there is a role, I mean, of course, Gina is kind of giving us this recommendation. So I think phenotyping is important before we decide on azithromycin.
Absolutely. So if the person is qualified for a biologic, I would rather give that. But yeah, Dr. Modi, please go ahead.
Yeah, maybe there are some category of patients, those who are basically asthma, COPD overlap. They have bronchiectasis on the scan, and they are having these recurrent infections, maybe bringing out purulent sputum. So they are the one where we can definitely try, and we don't have any such biomarker to find out they're actually Th2 low. So, and there may be the overlap of these patients. So if they have bronchiectasis, purulent sputum, recurrent infections, colonizations, I think they are the one where we can safely give it's up to maybe 6 months to 1 year, and then think about the biologic, which is not available with us. Then we can definitely in this category of patients we can use it.
Absolutely. Many patients can't afford the biologic, so that's a group you can try it also. And of course, try and monitor their hearing, because at least 10% of patients on azithro have hearing loss.
Has the hearing loss.
Yeah. So one of the other questions is, if a severe asthma patient is well controlled on inhaler, Dr. Sujata Sharda asks, how frequently should we repeat PFT and try and taper the inhaled corticosteroids? Dr. Thomas, patient well controlled, how often do you repeat PFT and try to taper, or would you repeat PFT at all and go by the clinical picture?
I wouldn't repeat the PFT at all because I don't honestly think it makes any difference. Number one, the ICS LABA is already on. He's already had the control that we want. So why do you want to do another pulmonary function test? I can't quite understand for the life of me why I would do that. I wouldn't do that at all. I would just go by the fact that this man is doing well with the treatment that I'm giving him, and I would just forget about the spirometry.
Absolutely. Completely agree with you. It's nice to have a number, but I think the asthma control test, for example, also gives us a very good
Exactly.
number.
Correct.
Yeah.
So, but still, will we like to de-escalate the steroid? Like if the patient is in the medium to high dose steroids, would you like to, like on the controlled asthma, how would you de-escalate it?
Yeah, good point. That is the other part of the question that Dr. Sharda asked. So, Dr. Thomas, how would you de-escalate
So basically, I think the question of adding the ICS in the LABA is to keep the dose of the steroid down. That's very simple. One of the main reasons why we use the LABA along with that is to keep it down. And if you want, you can add a third drug along with that and add a LAMA along with that and make sure that you get into triple and keep the dose of the ICS down. So I think the question of ICS down starts up front and not somewhere down the middle or at the end of it all. Try to keep the dose of the ICS as low as possible.
And I think Dr. Modi made a point about this when he said that there is a plateau effect. Once you start to cross, say, 500 of fluticasone propionate or 200 of fluticasone furoate or 800 of budesonide, you're starting to see a tapering effect. So we really need to bring it down to below those levels. Sorry, Dr. Pratibha, I think one of you were, or Dr. Nishita, you were going to add something.
So basically, there's these the 4 questions generally that Gina has recommended. Daytime symptoms, activity limitation, nighttime awakening, as well as reliever use. So, what we generally use is, if the question to none of them is yes, then we say that the patient is well controlled and we taper down the dose every 3 months. And if the patient, any question or amongst all these 4 questions, the answer is yes, then we say the patient is partly controlled and we continue the same dose of the patient. And if many are yes, 3 or 4 out of these 4 questions, the answer is yes, then we generally increase the dose.
And when you get it under control, do not reduce for at least 3 months of well-maintained control. I think that's really the crux of the question that was asked. We are at 10:30 and we have strict instructions to stop at 10:30. There are excellent questions in the chat box, but I think all good things must come to an end. I'm going to ask each of you to come up with just one take-home message for our audience, starting with Dr. Nishita. One line that you want to leave the audience with.
The underdiagnosis, the undertreatment of asthma is very huge. So always keep your eye open to diagnose patients correctly and to treat them correctly.
In fact, as Dr. Modi pointed out, 68 to 70% of severe asthma was not even diagnosed as having asthma. That's a very disappointing. Dr. Pratibha, your message.
So let's embark on the journey from uncontrolled asthma to controlled asthma.
Absolutely. For patients and doctors, most important. We've lost Dr. Avya, so I'm going to come to Dr. Modi. Excellent talk, Dr. Modi, I must say, and that's been coming up in all the messages we've received. Look forward to hearing you again and again. But one last message.
Thank you so much, sir. Something which I didn't say, but I feel that we should be using biologics more often, but I hate this word biologic because they're actually not immunosuppressant. They are like in rheumatic people where they have a lot of side effects. So we should be calling them something like disease modifiers or something so that, our patients will get more and more used to. But of course, for the patient, those who actually need it and not from the first visit itself.
Absolutely. So the use perhaps is precision medicine rather than biologics. So Dr. Thomas, the last word with you as always.
I think my dictum would be absence of symptoms is not absence of disease. Asthma is equal to compliance. Compliance is equal to asthma, and so be it.
Absolutely. So at the end of this, I think the most important messages that comes across is ensure that your patient adheres to treatment, catch the disease early, ensure adherence, choose the appropriate drugs, and most of your patients will get well controlled. But never discount what used to be called mild asthma. Treat it cautiously. And at the same time, severe asthma, we can make a big difference to the lives of patients. I'll stop at this point. Thank this brilliant panel for good discussions. Thank audience for logging in such large numbers and staying interested throughout. Thanks, Lupin, for continuing to sponsor this. And of course, a very special thanks to the ICS team, Dr. Salvi, Dr. Rajadhar, and of course, Dr. Amita Nene, who's been the heart and soul behind these programs. Thank you all very much.
Thank you, Dr. Murli.
Thank you, Murli.
Thank you.
Thank you, sir, for the
Thank you,
wonderful
Dr. Murli.
opportunity.
Thank you.
Thank
Yeah.
you.
Nishita, Dr. Pratibha. Thank you.
Thank
Good
you.
night.
Good night.
Lovely
Good
listening
night.
to all of you. Thank you.
Thank you.
Thank
Good
you.
night, everyone.
Yeah.
Thank you.
Yeah. Bye.
And a very
Thank
special
you.
thanks to the technical team. I forgot to mention them at the end. The tech team did a great job, kept things going throughout. Dr. Ms. Aditi and the rest of the team. Thank you all.
Thank you.
Thank you, sir.
Good night. Thank you. Good night, all.
Good night.
Yeah.